Yeah, good evening, Dr. Anil. We have Dr. V.T. Shah, Saurabh, Pratap, and myself on this side. And we'll have 3 cases, and we plan to show case by case for 10 minutes, which switching over in between the cases, depending upon the interest levels. And I request V.T. Shah sir a few words and start the live case sessions.
Yeah. Good evening, Anil.
Good evening.
Can you hear me?
Yeah. Good evening, sir.
Yeah. Good evening. Yeah.
Sir.
So, friends, we have Dr. Anil Potdar who will really show us.
Dr. Ramesh is here. I think you can join. You can
And
Ramesh Dagupati, sir.
Dr. Anil has been
Please.
pioneer of one of the
Sorry to bother.
live
please.
demo series of Intercity, conducts Mumbai and connects other cities for live demo every month.
Okay.
And he's an expert now in live demos. So let us see one good
Thank you,
case from him.
Thank you for kind words, and thank you TCT and Dr. Srinivas for giving me this opportunity. We have here Dr. Vedanti, Dr. Hamad, Dr. Nikhil, and Nelson and Samir. We have a team here. We will present a case. Can you go to the slides, please? Yeah, go next. Go next. So, your mic. Go. So, Dr. Hamad will present this case.
Good evening, respected panelists. So, our patient is a 74-year-old male. ECI to LED done in 2018 with the Zymes Expedition 3015, and COBA to L6 was also done 2OM. He presented with a history of chest discomfort and exertional dyspnea. His ECG and cardiac enzymes are suggestive of non-STEMI. He was vitally stable, and echo showed a apicoseptal hypokinesia with an ejection fraction of 45%.
Show next.
So this is a ECG. Here we can see T wave inversions in anterolateral leads. Next. And here is the angiogram.
Yeah, play. Can you see that? You can remove that.
Yes. Go ahead, please.
Something is coming on the screen here.
Yeah, we can see that screen.
We can see it.
So in the angiogram here, we can see there is a stent in LED, and it shows a instant restenosis at the ostial level. And also there is a significant disease just distal to stent in mid LED, and distal LEDs are diffuse. Play.
Next shot.
And distal LED is a diffusely diseased. Next. And diagonal ostium looks healthy. Otherwise, diagonal is also diffusely diseased just ahead of ostium. Next. And here we can see a dominant RCA with around 50 to 60% lesion in proximal RCA. Otherwise, RCA looks quite okay.
Yeah. So, thoughts, VT sir?
Yeah. So, can you show some view where the circ origin is clearly seen? Is there any caudal view or something? Then we can ask. Or you can give the impression. You can tell us what do you think about the circ.
We have taken here. Sorry. See this. You can see here. It shows this.
Switch.
You stop that.
To
Live.
We can't see the angio right now. We can only see you. So you could describe in the meantime, okay, now we can
Yeah,
see,
yeah,
okay,
yeah,
yeah, now
very
we can
good.
see the
Yeah.
angio.
So, okay, so you can see this.
So that stent in the LAD is right at up to the ostium, or there's a gap between.
There's a disease in the
Yeah.
ostial LAD stent.
Yeah.
You have a
Osteoproximal, there is tight instant restenosis. And we are not sure whether the stent is right at the ostium or it's slightly in the left main also. We are not sure. And mid LAD again, there is a lesion. The circ is non-dominant and absolutely a small size vessel. The superdominant is RCA. And there's a lesion in the proximal RCA also. So now, what could be the strategy? Any other risk factor which the patient has? Because the title here is chip multivessel PCI.
No, Anil, actually, basically, you have a LMCA is looking okay. There is an ostial LAD lesion. Circumflex, actually, we have to assess by imaging. So your plan should be, in this case, you took a 7 French catheter, I think. Now you put, what is the plan for you? You'll be doing a double wiring and
Yeah, because
assessment by imaging. That is what is your plan? What, can you just tell us how it is
actually we
your
thought
plan?
later with maybe FFR guided RCA. This for LCX for LED ostial. Now the issue was how to go about it. So first we we wanted to wire LED and diagonal both, and it's very tight lesion. So we wanted to dilate it and then do a OCT and see the status of the stent, what exactly it is showing. And
You will wire the LED and the diagonal. Circumflex, you are going to have a wiring or not?
showing. Circumflex, I have not wired because the dilatation was not coming till there. So, anyways, once
Yeah.
the balloon dilatation, we were not doing till that point. So, I thought, better to wire the long diagonal, because it is long actually and quite a diffuse disease till mid part. So my strategy was to keep it just patent, because if we go on tackling it, then we don't know whether how much length will dissect and how long stent we will have to place, and then what we'll achieve by doing that. So my thought on that was to keep it patent. Your any other thoughts on that? So we
When
are
you, well, what is the purpose of, I told you, why don't you wire into the circumflex? What is the purpose of wiring to the circumflex? When you do inflation on the osteoproximal LAD,
yeah,
do
so
you think a plaque shift can happen or not?
it can happen, but I thought that it's not diseased at present, so we wanted to dilate. We dilated basically the tightest lesion, which was in LED proper. Okay. And then we did OCT and saw exactly what is the issue. Then we thought that we will consider circumflex too, whether when we are stenting it, then also we'll consider whether to put a wire. The only thing is that putting 2 wires and at present,
Anil, that I understood. You have a problem of having multiple wires in the left system. That is okay. But when your plan of doing this procedure, you will understand the ostial LAD lesion, whether extending to the LMCA part or not. If it is extending to the LMCA, you should understand that whether you should go for a single stent strategy or a double stent strategy. In which imaging will definitely help you even to the circumflex ostium, because you are definitely dealing with an ostial LAD restenosis, right?
see the
Yeah,
thing,
okay, Anil, so
doing
you
that,
have pre-dilated and now you're doing the OCT.
I did not think that it will affect circ, to be frank. Okay, so I thought that we have wire in diagonal at present, so we will, when you are planning to stand there, then we will think of putting a wire. So first we dilated LED to enable us to do OCT there, and we did OCT after dilating the LED. And
Can you show us the OCT imaging? Perfect. We see it on screen.
yeah, So you can see from this distal part, which is nearly 2.4 millimeter in diameter, quite a
With
fibrotic,
a co-registration.
where we dilated actually, and very nasty dissection. Tightest part there. Actually, we did OCT from that point. You can see there, and actually the disease after that also it turned out to be the below, the lower part to that also. That I'll explain later. But this was the OCT. It showed multiple dissections, medial dissections, and you can see the stent here, starting here. It's just crossing, one strut is crossing the diagonal. Saw that?
Yeah, we can see that, right?
One strut, which is, across the diagonal. Otherwise, diagonal is more or less free of the stent. See, this is where, stent is 2.82 and it is nicely expanded there. Neointimal hyperplasia is evident all over.
Yeah, more of fibrous.
Fibrous, homogeneous,
Yes.
and yeah, even osteal part is, is dilated, means it's expanded well there. And you can see this is a bang ostium is covering. You saw that? So
What is the stent size at the ostium? At the LED ostium, stent size?
3
Stent.
No, size of the stent, you are saying now. The stent.
No. He was asking about the stent size, previous stent size, which you can see by the one marker from here, the other marker look like a 3 millimeter stent
3
they
millimeter
used.
stent. Yeah.
3 millimeter stent they used.
Yeah.
There is an neointimal hyperplasia there. But in the middle part where you dilated, you told there is a nasty dissection. We can see there is a calcium there.
Calcium.
I don't know.
Yeah.
Actually, the calcium was inside the plaque.
But there is 200-degree calcium nearly.
No, in the osteoproximal
Okay.
part, it is not there. In the middle,
Let's see.
middle area. You have to show again.
Let's see the distal left main. You can see some calcium here.
Here also there is calcium.
Yeah. From 3 to 12 and from 7 to 9. Come proximal. Let us see the distal left main.
See the distal left main, you can see the area.
Or there is a calcium there.
Yeah.
It is little deep.
So the stent struts of the LED are not projecting into the left main. They are not.
And the distal left main is 5.8. You can show that frame just ahead, just after the. See this. And when it is coming, it's like distal part of the left main is nearly 4 millimeter.
Yeah.
And once you come very proximal, then it is 4.5, 4.65.
Right. So Anil, the RCA, you said you did FFR?
Yeah, after this, after I finish this.
After this, you will do that. Okay. And this one now, what is your strategy? Please let us know, and then we'll move to the next center and come back to you.
Show the, down. When we took after dilating and after this, when we took a good picture, there was, you can see down, there is a still, is still there, same frame showing.
Yeah. So there's a dissection there, but also there's also distal disease, right?
Yeah.
Again, there is a, you can see there, that
Yeah.
was evident before actually. So we dilated there also after this. And then we did put a 2.5 by 48 stent, show the stent, which is coming just below the diagonal. And dilated it with 2.5 high pressure and in the proximal portion by 3/0. No, show the stent position. Yeah.
Stent.
Okay.
So you remove the LED wire,
No,
the diagonal wire.
diagonal one.
actually.
After this, after this complete dilatation of the LED, we did cutting balloon in the stent. We took 13 cutting balloon and dilated at nearly 12 atmospheres in the stent area.
In the proximal stent
Right.
with instant restenosis.
Stent.
Now this stent, is it covering that mid lesion also?
Distal
Yeah, distal.
Distal
Mid-distal lesion, that also you covered now?
is not extending distal to the diagonal.
Yeah, the second small diagonal which was
Right.
there.
Not
Beyond that.
Beyond.
Why did you remove the wire diagonal?
But it was cutting balloon, so I thought it will, damage the wire. So I just removed it.
Yeah.
It not cause-
So let me ask the panel, Anil, I think you put a long stent here. How many of you would have chosen a drug-eluting balloon in this
Yeah, I
area?
was just going to ask him the same.
Yeah.
And that was a lesion possibly could have been sorted out with drug-eluting balloon. A important site for even a Lima to LED for the future. And then proximally, as he said, he was going to do cutting balloon and overlap stent and all that could have been done, leaving that alone. That
So
was also a good option, I mean,
for OCT
for
picture,
long term.
medial.
And you already had OCT, so you had an imaging catheter to decide whether it will require a bailout stent or not.
Did you see that after dilatation OCT we did, na? That showed long medial dissections.
But actually, I did not understand why you removed the diagonal wire. Because actually the diagonal wire removal was not at all indicated now, because that is to be done later if you wanted to do that, and recrossing the wire was required. Because we thought diagonal is a larger branch, that is why you wanted to preserve it, right? So I think, Anil, we will go to the other lab and come back to you. So you can do more work, and then we will come and discuss with you. Again, is it okay with you?
Yeah, it's okay with me. Now see, now we have reached a stage where only thing, I'll take 1 minute. Is it okay?
Yeah, go ahead now, finish.
So now, we have stented because there were long and, medial dissections, very more than, 60, nearly a complete luminal dissections. That's why we have put a stent actually.
Okay, so what was the distal size you took, stent?
We took 2.5, distal was 2.5.
So now you finish your pictures along with the OCT and we'll come back to you.
Yeah.
Is that all right?
Oh, so the only thing is, what can be your strategy ahead now?
Yeah, but whatever you do, keep a wire in the sir. Otherwise, Pratap is not going to.
No, it is not like that. Actually, no, there are two things. You put a wire into the diagonal to preserve the diagonal. So when you put a stent there, you should have a wire there. And number one. Number two, you're putting a wire across the circumflexes basically because my intention is when you do a 2-stent strategy or 1-stent strategy, you don't know what is actually going to happen to the circumflex, and you have to preserve the circumflex and do an imaging.
So he said that when he does that provisional stent, he's going to put a wire, and he'll put, I think, and Anil is one of the proponents of radialist. He's a 7 French radial.
7 French.
Is it 7 French radial?
7 French radial.
Yeah, good. So anyway, you proceed and go ahead, and then let us see the final picture. So we go back to Mumbai.
अभी 2 millimeter दो.
Dr. Anil Potdar.
कौन सा? 2.5.
No, they have
2.5 दे दो.
Yeah, there.
वो जो stent के पहले. Okay.
I'm
You
giving you
can
there.
see that? Whatever.
Morning.
You can see the screen.
We already have red flag. So Anil, are you back?
Yeah.
Yeah, okay. We could see something just now. There was some slow flow in the circumflex, was it?
No.
We did not see, only VT saw. You can actually look at the.
Right.
Anil, you
So
tell the
let's
plan.
see. Yeah.
Okay. So we left you here, and now you show. So we thought, discuss. I wanted to discuss with you before doing this. As you saw now on OCT, there were a lot of dissections in the LED area also where we dilated.
Yeah.
So I thought it's not right to only do DEB. So that's why I had to put a stent down also, because there were dissections down also, and in the stent area also there were dissections. The thing is that the distal left main is 4 millimeter in diameter. Okay, and as it comes to ostium, it is 4.5. Okay, so 4 millimeters. So I thought it's, and distally I had to I cannot take one more stent, so I had to take 3O stent 33. So that's what I did, 3O 33, and
No. Anil, let us understand. You are telling that LMCA ostial part is 4.5. LMCA is 4 millimeters. What is the LED diameter?
LED 3.
Three only.
So.
No, but Anil, see, we just can't understand the expansion limit of a 3 millimeter stent
I
up to
understand.
4.5.
See, now
Which
but-
stent is this, by the way? Let us first ask him that.
one thing, Viti, I'll tell you.
Which stent? Ah.
You know the diagonal part, the cranial part. See, the thing is that I have to come with one stent. Okay, till this part. Okay, after the diagonal also. Saw that? So what is your choice then? It is not only in the stent, but I have to come out of the stent after the diagonal. If I had to take one stent, I cannot take one more stent. That's right.
What is the length
No,
of the
no,
stent now you have taken?
No, and what?
No, let me,
Yeah.
1 minute. What is the length of the stent you have taken?
33.
33. You could have taken a 38 stent and come up to the ostium, and that actually there is no problem in that. Number one. Number two, why don't you take a 3.5 stent? And 3.5 you can go and dilate up to 4.5 in the LMCA part. Then what is the problem in 3.5?
Yeah, but I think the distal it will not match, 3.5. Even if it,
But you are landing in a stent distally, you can always go at 6 or 8 atmosphere and come out. Would not have been a problem. But anyway, now you have taken 3 into 33, right?
So 3 into 33, then I have,
No, but what is the make of the stent? We didn't understand that.
33.
No.
giant stent, Alpine.
Alpine.
So Alpine stent. So I think capability of Alpine is good.
We can go up to 4.25.
Yeah.
But the point is actually just I'm telling, when you do a balloon dilatation as the pot in the LMCA part, you have 3 millimeters in LMCA's uncovered part. I'm telling you, when you take a pot balloon in the LMCA part, 8 millimeters, you are going to create a dissection in the osteoproximal part of the LMCA. That is what I feel.
I kept it 8 millimeter in the LMCA and I did pot with 8 mm. I have done that.
So are you doing a pot balloon now?
I
Yeah.
did.
Did you use a pot balloon?
I did not use pot balloon, but I did 8 millimeter, 408 millimeter.
408. Right? Yeah. Okay. So we'll see on imaging whether the opposition is there or not.
We'll dilate the 3O stent first. Give me 3O.
Yeah. Let us finish that. We'll do that final. Anyway, so now
So
we have covered that. Okay.
and then
We have done the pot.
show next. Show next. Show the images next. So this is where we are.
No, he has done the pot.
Yeah.
Then he has removed the wire of the circumflex and he's rewiring.
Yeah, I have rewired both now, diagonal and LCX both.
Correct.
Go to cranial.
Osteoproximal part of the LED is definitely underexpanded by angiographically.
So I have not actually now I have not expanded the stent.
So what size of balloon will you take for the ostial part of the LED?
Now it is.
Anil, actually, I just wanted to understand what size of balloon will you take? 3.5, definite, right?
Which one?
What osteoproximal part of the LED will you dilate with it?
What I'm thinking,
3.5 balloon, right?
what I'm thinking, distally I will dilate with 3. And ostial part of LED, I will go with 3.5. That's what is my plan.
Okay.
Is it okay?
Yeah. That's all. Another 5 minutes. Yeah.
You can go.
Please go ahead and then let us see.
Let us see, but we wanted to
Yes.
see the imaging. We want to see the apposition. We will come back. Actually, can you dilate or we are going to come back?
You can come back then.
Just dilate and then by the time we will come back and we'll go to the next center in
Now
Ahmedabad.
Yeah.
And can you just go to the final comments from the
Dr. Anil Potdar,
Anil?
Yeah. Can you hear me?
we are with you for the next 5 minutes. Please show us what you have done after we left you last.
We came to you first. We are actually coming to you last again.
Show the last one.
Can you show? Okay.
No, before. Radio has.
Like they're stamping this segment in the middle.
See, this is the last. Show the OCT run. OCT का जो नहीं मुझे picture है OCT का वो that has come good. पुढे. See. This is a picture, last picture. OCT shoot. Saw that? You can hear? You can hear me?
No, it's not moving. The picture is not moving. It's a still frame.
Yeah, play the OCT.
Showing that same thing.
If you could play the OCT for us.
OCT, please.
Okay, you.
Yeah, now it's moving. Now it's moving.
So you did not see angio, but you can see that OCT image.
Yeah.
See here, it is. Show the area.
Okay, come back proximally.
Yeah, come back proximally. There are some areas, which are showing some under expansion, which you can see there. Here, one is there, and go next. Come proximally. Come down. Yeah. Okay. Here. Yeah, proximally is 90%. Only two areas is showing like less expansion. When you set at 90%, when you set at 80%, it's looking up, acceptable.
80% is a minimum expected one. If it is more than 90%, it's ideal.
Yeah. So these two spots, then again I dilated again. See this stent into left main.
Oh.
That is a blood there, blood speckle. Otherwise, it's okay. So this is
Can you show the SIR costume in this?
इसमें,
There's no edge dissection here.
yeah.
There is no edge dissection.
Yeah.
The stent is well opposed in the
Yeah.
LMC. These are the 2 points, very good points here.
But distally, the stent was 2.5. The diameter is only 1.95 millimeters that you got.
2.5 is 1.25 into 2.25 into 3. That will be, we expect nearly 6 millimeters square.
But
It's a
you got only
2.5.
three square millimeters. So, I mean, that's why I'm saying that in a distal LED, small vessels, I actually try to either just leave them alone with a balloon, or at least in India, you have the luxury of a drug-eluting balloon. But now we put a stent, and it is measuring at 3 square millimeters, and diameter is 1.95. What would you do, Pratap?
Yeah.
Distally.
Actually, now I have to finger cross and pray to the God that patient should not come back with a restenosis.
Exactly. I think we need to be very aggressive with medical therapy, with lowering the LDL probably to 35 to 40 and DAP forever.
That is what actually we should always calculate, that what is the expected area what we require in that. At 2.5, you require 6.3 or 6.4 millimeters square is the requirement. If you get a 2.5 in that part, that is actually less than 50%. Definitely it is.
You require 5 square millimeter.
More than that,
millimeter for a
1.25 is 2.25, 2.25 into 3 is 6.3. You just calculate that. Minimum 6 into 8 is 4.5,
Yeah.
4.8.
So,
We are happy with 4.8.
so that's very good. If you want, our suggestion is to proceed with post-dilatation of the distal. Otherwise, I think this is very good. So any learning points from you, Dr. Potdar, before we leave you?
No, he should tell.
Huh?
Just
I mean,
tell Anil, what is your opinion? What is your learning point messages to us?
So basically now this case actually posed a lot of challenges, actually speaking, because it was bang ostium. So whether circ was involved, one. Second thing, diagonal was a long vessel, but very diffusely diseased. So whether whether that occludes. So these were the things which patient wanted intervention only. So and the long lesion in the LED. So ultimately, I think OCT guided intervention, I feel that is always may give a long-term result. So whatever we have done till now, imaging guided, PCIs, they have shown excellent result, excellent long-term outcomes. Even bifurcations, we have done so many, and once they are imaging guided, I think they have not come back, I will say.
Message should be short. Message is very long. Message.
No, Pratap, it's not only from you. Other people also.
Other people also now actually, Anil, what you did is actually you made Ramesh to think that all the Indians are talking like me. It give a long sentence. One sentence make like a paragraph. What I just wanted to tell you that in LMCA you just use a 4 millimeter vessel. You can see the stent struts are very much expanded, and there is you can see that stent is very much expanded and that created a lot of area there. Anyway, sort of,
Good.
Uh,
So I
yeah,
think we conclude.
I think my initial strategy for this, even in retrospect, seems right, which is to treat the distal vessel with a drug-coated stent and then a drug-coated balloon, excuse me, and then probably stent proximally. My own bias here, if I were doing it, would be to spare the distal edge and post-dilate it and get a slightly better lumen. But leaving it as, I think you just have to hope and I don't like hope. Hope's not a great strategy.
Yeah, go ahead.
what are the learning messages?
So
I think
I thought-
there are few takeaway points from Dr. Anil's case. Of course, first of all, whenever we have dissection in the mid LAD, even if Dr. Antonio Colombo may leave it for medical management with DAB, definitely in Indian scenario, none of us would leave it like that because it was a ghastly dissection. And I do agree with Dr. Anil's, decision to stent it just after dissection, not before that. And secondly, of course, we could have probably taken a longer and a little bit bigger stent. Whenever left main was 4 and distal LED is 3, we can use 3.5 and little longer. We could have covered entire left main, as Sir said sometime back. So these are the things. And of course, since it was a non-dominant circumflex, the RCA was very big, large, dominant. So, and the diameter was not very big. So it was, I think, many of us, we go across the circumflex, and unless there is a pinch or something, or maybe we just go provisional stenting, because natural, progression of atherosclerosis is much slower than the, instant restenosis. Then that's what is there. Of course, the concern in this case would be distal LAD malapposition, which still you can post-dilate it with a little larger NC balloon 2.5 or 275 or something for a, long-term better results under
Yeah.
expansion.
No, I think Anil, congratulations for you to show us this image guided. It did help us in making decisions, and more important is to get a good result at the end of it, whatever strategy you might have, because imaging will tell you the exact areas and dissections and all of the details. So congrats. Thank you very much, Anil, for that case. We move on to the lectures now.
It's actually not giving a chance to talk.
There is one more saying in intervention cardiology: perfection is the enemy of success. So if we want to succeed, even if like last two cases we had some stents of LAD protruding into left main, some struts of circumflex protruding into the left main, but overall the result was good. So I think instead of trying to be perfectionist, I think we should be successful, and that's what I would say.
No, and do whatever you are comfortable with.
Thank you very much, Anil. Great demonstration. We are going to end with you and move on to the lectures. Thank you.
Thank you very much. for the
Thank
opportunity.
you.